Most people are told they need surgery because they skipped the first 3 steps of the recovery pathway. Today, I'm showing you the stage roadmap, the exact order you should follow to heal without an operation.
Because honestly, right now, clinics all across the country are filled with people clutching MRI reports.
Oh, yes. In those big plastic folders.
Exactly, those big plastic folders. And they are staring at the word herniation, and they are just absolutely panicking.
They walk into the consultation room convinced their spine is practically crumbling.
And see, it is completely understandable. I mean, you read a medical report you don't fully understand, maybe you Google a few complex terms, and your mind immediately jumps to the absolute worst-case scenario.
A massive open surgery.
Right, but the reality is actually the exact opposite of that panic. Most chronic back and leg pain improves wonderfully with a blend of the right treatments. It is never a situation where, you either get a magical quick fix today or your spine gets cut open tomorrow.
Which is such a relief to hear. Welcome, everyone, to today's deep dive. Our mission today is to sit down with you and unpack the actual clinical guidelines.
We really want to clear up the confusion.
Exactly. We are breaking down a comprehensive step-by-step presentation from a senior surgeon to completely demystify the non-surgical roadmap for back pain and sciatica.
So you know exactly what you need to try and in what order well before a scalpel is ever even discussed.
Right. So let's jump straight out of that MRI panic and into the very first step. You leave the clinic, you go home. What is the very first instinct most people have when their back goes into spasm?
They get straight into bed?
Yep. They get into bed and refuse to move.
Which is, I tell you, the biggest myth we have to bust right now. When it hurts, your brain just tells you to freeze.
It's a natural protective instinct, though.
It is. But the clinical guidelines strongly emphasize that you must stay active. If you just lie down on a flat mattress for a week, your recovery goes completely in reverse.
Yeah, really.
Oh, absolutely. The muscles in your back go into a prolonged spasm. The joints literally stiffen and lock up, and your disability gets so much worse. You have to keep moving.
It feels counterintuitive, but staying active is the foundation. And the source material really leans into this foundation, adjusting your mechanical load.
Things like how long you sit, how you lift objects.
Fixing your workstation ergonomics so you aren't in these prolonged static postures all day.
And then, of course, they bring up weight management.
Yes. The mantra here is move more, eat smarter, rather than going on some extreme crash diet. But come on, let's be realistic. You know how patients get.
Oh, I know exactly what you're going to say.
Right. You sit across the desk from them. They are in absolute agony with shooting pain going all the way down their leg. And you tell them to manage their weight, fix their sleep, and stop smoking.
And they look at you like they want to throw that MRI folder right at your head.
Exactly. They feel completely cheated, like you're just brushing them off with polite wellness advice. I have real pain, doctor. Why are you telling me to sleep better?
It happens every single day. See, they think it is just soft medicine, but it isn't just general wellness talk. It is pure, hard biology.
Okay, break that down for us.
Let's take the spinal discs. Your spinal discs do not have a massive direct blood supply of their own. They are what we call avascular.
Avascular, right.
So they rely entirely on the tiny blood vessels surrounding them to pull in oxygen and nutrients through a process of osmosis.
Okay, so they essentially need the surrounding environment to feed them.
Precisely. Now, when you smoke, you physically constrict those specific blood vessels. You are literally choking the blood flow to your spine. The disc starves, it becomes brittle, and it simply cannot heal the damage.
So telling a patient to stop smoking isn't a moral judgment.
Not at all. It is a structural necessity to save the disc.
That makes total sense for smoking. But what about sleep? How does missing a few hours of sleep physically damage a disc in your back?
Well, it doesn't damage the disc itself, but poor sleep biologically alters the brain. It actually amplifies the pain signals.
It turns the volume up.
Exactly. When you are sleep deprived, your entire nervous system goes on high alert. The physical injury hasn't changed at all, but a pain level that should naturally register as a 4 suddenly registers in your brain as an 8.
That is fascinating.
Think about it like an everyday situation. Imagine you are carrying heavy grocery bags, 5 kilos of rice, heavy bags of dal up a steep flight of stairs.
Okay, I am picturing it.
You are trying to balance them. Now imagine doing that while the pillars holding up that staircase are crumbling. And on top of that, you haven't slept for 2 nights, so your balance is completely off.
You are definitely going to drop the bags or fall down.
Right. That extra weight you are carrying is the mechanical load on your spine. The crumbling pillar is the lack of blood flow from smoking.
And the stumbling is your exhausted nervous system.
Exactly. If we don't fix those pillars and put down some of that heavy grocery load, no amount of advanced structural repair on the roof is going to save that staircase from collapsing.
If the foundation is weak, even surgery won't give you a permanent fix.
100%.
So you have to put down the heavy groceries, fix the pillars, and get some sleep. The foundation has to be set.
It is non-negotiable.
But, once those daily habits are optimized, the patient is still staring at you, terrified to actually bend over and pick up a box.
Because the fear is still there.
Right. How do we get them moving without causing a massive spasm? Because that brings us to the next step on the roadmap, which is physiotherapy.
Yes, phase 2.
Now, when most people hear physio, they just think of passively lying on a clinic bed, getting a nice massage.
Or maybe having some hot packs applied.
Yeah, or having those little buzzing electrical machines put on the back.
And see, if you are just passively lying on a bed while someone does something to you, you are only getting maybe 10% of the benefit.
Only 10%.
Barely. True, effective physiotherapy is structured movement coaching. The biggest hurdle we face is something called kinesiophobia.
Which is the fear of movement.
The absolute fear of movement. I see patients all the time who are so frozen in fear they won't even turn their neck to look at me.
That sounds awful.
It is. So a good physio doesn't just start yanking on your limbs. The very first step is education and reassurance.
To explain what is happening.
Exactly. They explain the mechanics of back pain to actively reduce your fear, showing you that hurting does not necessarily mean you are causing harm.
Right, because fear makes you tense up your muscles, and that tension just creates more pain. It's a vicious cycle.
Yeah, terrible cycle. But once that fear is reduced, the physio guides you through structured exercise programs. The goal is to build flexibility and specifically target your deep core and hip strength.
So we are essentially building the body's own internal brace.
That is the perfect way to put it. The manual therapies you mentioned, the spinal manipulation, the massage, they are definitely supported by clinical guidelines, but only as one small part of a much wider exercise package.
They just give you a temporary window of relief so you can actually do the exercises?
Exactly.
So it's not like going to a spa to have someone just fix your back while you relax. It's actually more like hiring a structural engineer to help you build an internal scaffolding for your spine.
Right. I love that analogy.
Yes.
The physio is handing you the blueprints and showing you how to mix the cement, but you are the one who has to do the heavy lifting to actually build that scaffolding.
That is exactly the dynamic. The scaffolding is made up of your deep back muscles in your core. If your internal scaffolding is strong and active, the physical load is taken off the injured disc.
You have to do the work to build it.
You really do.
But let's look at a really practical hurdle here. What if you, the patient, are in so much absolute agony that you literally cannot attempt this movement coaching?
Which happens frequently.
Right, you can't get on the floor to do a stretch. You can barely even stand up straight to brush your teeth. We don't just throw our hands up and book the operating theater.
Never. This is where we bridge the gap. We bring in the chemical helpers and we address the mind.
We never jump straight to surgery just because the pain is high on day one.
Exactly. We use medicines as chemical helpers to build that bridge.
Yeah.
The guidelines recommend starting simple, paracetamol and short courses of basic anti-inflammatories.
Just your standard over-the-counter NSAIDs.
Yes, just to help reduce the active swelling around the inflamed nerve. And if it is sciatica, that sharp electric shooting pain going down the leg.
Which is so painful.
Very painful. We might cautiously introduce specific neuropathic agents, which are drugs designed specifically to calm down angry nerves.
Yeah, but there is a massive flashing warning attached to this in the medical sources. Stronger is not always better.
Oh, this is so important.
People always come in asking for the strongest painkiller available.
Always. But we have to be incredibly cautious with strong opioids. The guidelines generally do not recommend the long-term use of opioids because they have very limited benefit for chronic spine pain.
And the risk of dependence is incredibly high.
Extremely high. Medicines are helpers. They are not cures. You use them to dial the pain down just enough to support your movement and your physio.
You do not use them to replace the movement entirely.
Never.
So they are literally just the bridge to get you back to the structural engineer, the physio. Now, here is where it gets really fascinating, but also incredibly tricky to navigate in a real clinic.
The psychology aspect.
Yes. The sources talk about psychological and pain education therapies. things like cognitive behavioral therapy or CBT to address fear, avoidance, and unhelpful beliefs.
It is a crucial part of the roadmap.
But let's be completely honest.
Yeah.
If you tell a patient who can barely walk that they need psychological therapy for their back pain, they will immediately bristle.
They absolutely will.
They hear it's all in your head, you're imagining the pain.
Yeah.
How do you explain this to someone without deeply offending them?
It requires a lot of empathy because people naturally feel completely invalidated when you bring up psychology in relation to physical pain.
Of course they do.
The very first thing I tell them is, listen, your pain is 100% real. You are not imagining it. It is not fake.
That validation is key.
It is, but we have to understand how the nervous system actually works. Back pain is absolutely a physical structural issue, but your mood, your deeply held beliefs, and your stress levels heavily influence how that pain behaves in your body.
The brain is essentially the control center for everything we feel.
Think of your nervous system like a volume dial on a stereo. When you have a physical injury like a disc bulge, the volume dial is naturally turned up.
Because there is real damage.
Right. But when you are stressed at work, when you are suffering from low mood, when you are sitting at home terrified that your spine is irreparably broken, your brain dumps stress hormones like cortisol into your system.
And what do they do to the dial?
Those hormones literally crank that volume dial to maximum. The physical injury in your back hasn't changed size, but the volume of the pain signal reaching your brain is deafening.
Right, so the physical disc bulge hasn't changed by a single millimeter. But because they are terrified, or because their boss yelled at them at work, their brain is literally screaming that the back is broken.
Exactly. Psychological therapies, CBT, and pain education, they do not fix the disc, but they teach your brain how to reach out and manually turn that volume dial back down.
They reduce the nervous system's distress.
That is why multidisciplinary programs are so effective. You are treating the physical structure with physio and treating the nervous system's overreaction to it at the exact same time.
We all know what that feels like.
No,
You have a mild headache, and then something incredibly stressful happens, and suddenly the headache is unbearable.
the physical headache didn't change, the stress amplified it.
Such a great way to explain it. So we've gone through the lifestyle foundation, the movement coaching to build scaffolding, the chemical helpers to bridge the gap, and calming the nervous system's volume dial.
A lot of ground covered.
But what if a patient has honestly tried all of that? They did the work, but they are still completely stuck. The pain is still too high.
There is one final non-surgical doorway to unlock before we ever consider an operation: targeted tools.
Okay, let's talk about phase 5.
If the lifestyle and the basic medications leave you stuck, we can step in with targeted injections and specialized pain management services.
Like what kind of injections?
We use things like epidural injections, nerve root blocks, or facet joint blocks. What we're doing here is delivering a highly concentrated dose of anti-inflammatory steroid right to the exact pinpointed spot where the nerve is inflamed and angry.
But the source material is very careful with how it describes these injections. They are not magic cures.
Far from it. And that is a very dangerous misconception we see often. People think, I'll just get the injection, my back is cured forever, and I can go back to my old habits.
That is so common.
Evidence suggests injections help some people tremendously, but they are targeted tools. They are designed to cool down the inflamed nerve and offer a short-term window of relief.
Let me clarify this, because it's such a crucial takeaway for anyone listening who is considering an injection. If the inflamed nerve is a kitchen fire preventing you from walking in and fixing the broken stove, the injection is the fire extinguisher.
That is a brilliant analogy.
It puts out the flames temporarily so you can safely step into the kitchen and do the structural repair, which is the physiotherapy and the movement coaching.
That is the perfect way to look at it. If you just use the fire extinguisher but you don't fix the stove, the fire is just going to start again the minute the extinguisher foam wears off.
Right.
If you get the injection and go back to sitting passively on the sofa, the pain will simply return. You have to walk through the window of opportunity the injection gives you.
And alongside this, for people with very long-standing stubborn pain, we involve pain management services.
Yes.
And what is the real goal there? Because it sounds a bit different than just trying to fix a disc.
It is a complete shift in perspective. Pain services focus on a multidisciplinary review and optimizing your medications. But the true goal is improving your overall function and reducing your distress.
Managing the reality of it.
Exactly. It is about supporting realistic expectations. The goal shifts from chasing a magical 0 on the pain scale to focusing on living better with less pain.
Getting your life back.
Getting your mobility back, going back to work, even if there is still a background hum of discomfort.
Which is such a healthier, more sustainable mindset for chronic conditions. Now, before we move to the final stage, the guidelines also explicitly state what to avoid during this whole process.
Very important points here.
We've mentioned the dangers of long-term opioids, but they also advise against routine traction and those stiff lumbar braces or belts you see people wearing tightly around their waists all day long.
When you wear a stiff lumbar brace all day, your body starts to rely on that external support to hold you up.
It acts as a crutch.
Precisely. As a result, your own internal core muscles, that scaffolding we worked so hard to build in the physio phase, they get lazy, they weaken, and they atrophy.
Oh, that makes sense.
So when you finally take the brace off to take a shower or go to sleep, your spine is actually far more vulnerable and unsupported than it was before you put the belt on.
And what about traction?
As for traction, the routine use of it just isn't supported by robust clinical evidence for long-term recovery.
It's all about building your own internal strength, not relying on passive external fixes.
Exactly.
Okay, so we have walked the entire step-by-step roadmap. We cleared the foundation, we built the scaffolding through movement, we used chemical helpers as a bridge, we turned down the volume dial in the brain, and we used targeted injections as a fire extinguisher.
We did everything we could.
So the ultimate question, where does the operating theater actually fit into all of this?
It fits at the very end of this road.
The very end.
Yes. Surgery is only discussed when the pain, or more importantly, serious neurological deficits.
What does that look like?
Things like significant progressive weakness in your leg or foot, or a sudden loss of normal bowel and bladder control. When those persist, despite a good, honest, thorough trial of this entire step-by-step pathway.
An honest trial being the key word there. You can't just skip from a bad sleep schedule to a scalpel.
No, you cannot. If you genuinely follow this roadmap, we find that most second opinions lead patients right back to health without ever needing surgery.
That is amazing to hear.
No single treatment suits everyone, which is why a tailored combination of these steps works the best.
It really is about trusting the process and giving your body the right environment to heal itself. As we wrap up today's deep dive, I want to leave you with something to really chew on, something that builds on everything we've just discussed today.
It is a really interesting thought.
We've learned that poor sleep, stress, fear, and low mood biologically and physically amplify spinal pain. When you look around at our modern world, we clearly have a global epidemic of chronic back pain.
We really do.
But it makes you wonder how much of that is actually just a physical symptom of our modern epidemic of stress, constant connectivity, and burnout. Are our spines literally carrying the weight of our overactive, exhausted minds?
It forces you to look at back pain in a completely different light.
It does, doesn't it?
It is a very profound thought, and clinically, there is a lot of truth to it.
Yeah.
We always have to remember, we treat the whole person, not just the MRI scan.
So true. Thank you all so much for joining us today and letting us guide you through this. Please say this deep dive and share it with anyone you know, a family member, a colleague who is currently panicked, holding an MRI folder and asking, what can I try before surgery?
Empower them with this roadmap.
Until next time, stay active, sleep well, and take care of your foundation.